I think Chisholm has started the recording, so just to let you know that we'll record a session and then make it available. If you're happy with that. Is this your last day, Nora, before Christmas, or are you still working?
No, it's different from Cambridge. Therefore, it's tomorrow is half a day. We have an off, the gift, so
Right.
it's a working day until tomorrow.
Okay.
You've already started the Christmas festival.
No, end of tomorrow. End of tomorrow it starts. Yes. Yeah, I'm just taking leave tomorrow so that I get to do things before Christmas that have not been done.
But we only take the that were given by it's the Christmas and the Boxing Day, 27 to 29,
Right.
14 days, but you take them as your annual leave rather than a gift. As you said.
Okay. Whereas we're off till the 2nd, as you know. And this, I think this year is a bit shorter than usual. Usually, I think it's a longer period. I think because it doesn't fall on the weekend. So, but it's always busy even at that point in time, as you know. Welcome, everyone. I think we'll just wait for a few more minutes before everybody joins, and then we'll make a start. Okay. And welcome. I'm just looking at the clock. It's not even 2 o'clock, so if we just give everybody 2-3 minutes more. It's the same as when we teach online, the students don't come exactly on the hour. It's 1 or 2 minutes, and they're there. I think it's the sort of post-pandemic, everybody has a bit of a different clock or different watch, but it's all within 2 or 3 minutes or around there.
But sometimes it takes then for Zoom starts updating or it doesn't work or ask passwords, it takes longer, that's why.
Yeah. And here's Scott. Hi, Scott. Hi, Nirmala.
Hi, Alex. Hello, Nirmala. We'll just wait for some more people to hook up here and then get started. And Alex, I'll turn it over to you for introductions.
Sure, absolutely. And Scott, just to introduce you to Nora. I've been working with Nora for a number of years on, I guess, in education capacity, but also other sort of discussions. So
since you're being it's let's say it's 12 years old.
You're both so young. You must have started working together when you were teenagers.
Yes, before you.
It's the Zoom filter. If there's one filter that
I need that filter. Please tell me how to load it onto my laptop.
I don't think it exists, unfortunately, but
someone could make a pretty penny if they came up with something like that, though.
Wrongling is here as well. I think we have quite a good turnout. So
so far. I think some more people are joining.
Yes, which is great for a couple of days before the Christmas break. In the past, we have had even less participants on less precious weeks. So this is really great.
Good morning, good afternoon, good evening.
Yes, exactly.
For those of you just joining, this is the Global Genomic Medicine Collaborative webinar. We'll start in just a minute. We're waiting for people to join.
Hi, Chisholm. Hi, TG. Welcome. Welcome to everybody else. Okay, so Scott, I think we have quite a number of attendants on the call.
I
Probably, and probably we should make a start.
I think we should. Let me again just welcome everyone to the Global Genomic Medicine Collaborative Educational Webinar. It's a series we have pretty much monthly. We try and keep on that schedule. Today we're going to hear from Professor Nora Pashayan, and to introduce her is one of our leaders of this group, Alex. Alex, would you please do the introduction?
Thank you, Scott, and welcome to everybody. Thank you so much for joining this webinar, whether it's in your morning, afternoon, or evening. So it's great to see you all here. It is my absolute pleasure to welcome Professor Nora Pashayan here, who is a colleague of mine. Nora is a professor of Epidemiology of Ageing and honorary consultant in public health medicine at the University of Cambridge. She's a cancer epidemiologist, a clinician with specialties in both family medicine and public health medicine, and the director of training for the Cancer Research UK International Alliance for Cancer Early Detection. Her primary research field is cancer early detection, risk stratification, and population level screening. And her research focuses on understanding disease course, evaluating screening strategies, and implementation of novel screening strategies. So today she'll be talking to us about personalized risk assessment for early detection of cancer. Welcome, Nora.
Thanks very much, Alex, and it's really a pleasure to be here. It's the last probably seminar of the year. So what I will do in this coming half an hour or so, it's not looking into the discoveries of genomics, but rather we were going to look into how we can bring this into the clinical practice. So it's not an easy road. There are multiple factors there. It's a jigsaw puzzle, but the problem is it's not a two-dimensional puzzle. It's more like a Rubik cubic. You change one aspect, you need to change all others. And I will talk through this. So I will be talking about how to do bringing this to clinical practice, and particularly looking into setting off in cancer screening. And I will look into some of the considerations like in risk assessment, the strategies, the evidence, and give example of an implementation study ongoing in Canada, prospective INI study. So first to start, what is this precision screening or risk stratified screening? Basically, you have your population. What we see here is that we have a 10-year absolute risk of this woman in Canada of having breast cancer. And what we see is the risk increases with age, of course. What we're doing here is we do risk assessment of for every woman in the population. So here we have, so let's look into a woman age 60. The average woman of age 60 has a 10-year risk of 3 to 4%. Whereas if you look into it, if you do the risk assessment, and you would see that there are risk varies between women. Some women will have a risk as low as less than 1% in 10-year risk, and some women would have a risk as high as 9 to 10% 10-year risk. So there is a tenfold more difference in the risk in the distribution in the population. So once you've done the risk assessment, the third step is you define the cutoff point, and then you stratify the population into different risk groups. In this particular example, we have 3 risk groups. And the purpose is you want to change the way you do your screening differently to every risk group. You change the age of start and stop of screening, the frequency of screening, and the modality. For example, in breast, for a high risk, you might add an MRI in addition to mammogram. Now, as simple as it looks, the 3 steps: risk assessment, risk stratification, and tailored screening, but there are multiple questions yet to be answered. First, about risk assessment, the question is, which risk factors should be included? When should we do the risk assessment? Is it one-off or it should be repeated? How often? And how we're going to collect this risk information at a population level? What about the risk stratification? Of course, we need to know how many risk groups. In this particular example, I have 3 groups. Why not 4? Why not 2 groups? And what is the risk threshold and what metric should we use? I've used here the 10-year absolute risk. Why not to use, you might ask, a lifetime or remaining lifetime risk? And the question is whether we should have the same risk level applied to all of them, or we should be varying the risk level by age. And even when you're done, we're looking to risk tailored screening. So which strategy is for which group? Where is the evidence and what type of evidence do we need? Do we need always to have a randomized controlled trial? And also when you're doing this all risk tailored screening, what's the purpose? What are the outcomes we want to optimize? And then how to organize such screening program. So I will be looking some of these questions. First of all, which risk factors? Let me start. I'm taking here again example. Right, so I'll miss this. For all these questions, before I go there, the how and why and which will define whether our screening program will look. And this will define whether the program is going to be effective. Effective means whether it does more good than harm, and whether it's going to be value for money. Is it cost effective? Is it feasible to run such a program at a national population level? And would this be acceptable to the users, the public, and to those who provide the services? And would this be available, accessible, equitably? It should not create more inequalities. Now, all this, of course, we need the research evidence, but also we need resources. Resources include time, trained professionals, and also technologies, like the labs to do the risk assessment or the genetic analysis. But also we need to look into the societal aspects. We need to, therefore, whatever we do, it has to be congruent with and to the values and the preferences of the population we're dealing with. And of course, this we need also to look from the healthcare system. So if there is a screening program is something else than if you're going to set up a new screening program. And also it depends on how the system is flexible and it is adaptable, and whether there is a learning system where they can accept to start implementation, learn from it, use, for example, electronic health records, use the data, modify, and come back again, or whether therefore this is not acceptable, and how much the organization is ready, how much people are willing and think that they are able to do. So there are multiple factors that affect to bring this into practice. Now I go back to the risk factors. So the question is which risk factors? I'm taking here example from breast cancer. So if you look here into, it's similar to looking into area under the curve, which is a way of looking how good it is, a test in discriminating between someone has a cancer or not. And an area under the curve, if you look into a value of 0.5, it means like a toss of a coin. It's by chance, you can't differentiate. And the perfect discrimination is if you have an area under the curve of 1. Now in breast cancer, if you look into the epidemiological risk factors, like having age of menarche, age of menopause, age at first birth, alcohol intake, the smoking, body mass index, hormonal intake, whether HRT or oral contraceptive pills, and family history, all if you combine them together, it will give you an area under the curve of 0.6. Now, if you look into the genetics, and here we have a genetics means I'm looking into the common genetic variants or the SNPs, and then combine them into a polygenic risk score. And taking the for breast cancer at the moment, the best polygenic risk score is based on the 313 common genetic variants associated with breast cancer. This themselves, they are to give you a better area under the curve of 0.63. And of course, if you combine them together, you get even better. And if you add to it the orange line, the mammographic density, which is an important risk factor, even you get a better area under the curve. Now, there is an ongoing study, the Confluence, which is funded by the NCI. Now this will be the largest genome-wide association study with 300,000 cases and 300,000 controls. And one advantage is that it's looking into people from different ethnicities, because so far the discovery of the SNPs had been mainly in people from the European ancestry, which limits its use in the population level. Now, this pan-ethnicity polygenic risk score, the predicted result is very promising. We expect to see the results next year. Now, if you, therefore, this gives us much better, but there is combining all the new SNPs together with the epidemiological with mammographic density. And there is one more study, therefore one more area of a field, a new field that's coming on, which is using epigenetic markers. Now, the epigenetic markers, they are in a way, they look into both the genetics and the environmental exposures they combine. Recent study by the team by Martin Wichwenter, who used to be in the department that Alex runs, is identified a DNA methylation signature from taking cervical cells. This can be used for predicting or early detection of a woman's cancer. So the WID, the Woman's Risk Identification for Breast Cancer Index, it has an area under the curve of in itself 0.81, but of course this needs further validation prospective studies. Now, what do all this mean? Therefore, we're not going to use, therefore in screening setting, we're not going to use just for prediction. We're using the risk assessment in order to do risk stratification, how good they are for stratification. So let's look into this, the proportion of the population at highest risk. Supposedly, we're looking into 50% of the population at highest risk. If you do nothing, and the population, you would expect that for 50% of the population should have the 50% of the cancers. Now, if you use epidemiological factors, you could identify 62% of the cancers within this 50% of the population. However, if you use the currently known polygenic risk score with other risk factors combined, in the 50%, you would identify 75% of the cancers. And in the future, we would expect this, the other risk factors, the new polygenic risk score or the epigenetic markers could be even better. So what does this mean? So let's look at it into distribution of your curve. So the blue line is the one that is using only epidemiological. What we see, it's the variance is smaller. It's a narrow curve, whereas the more risk factors you've added, the curve spreads better. Therefore, the variance is larger, which means you can identify better the individuals who are at the tail of the distribution. Okay. So let's give you an example. Let's take someone who has therefore log relative risk of 1 or relative risk of 2.8-fold higher than the population average risk. If you got this cutoff point and you're going to say, this is the cutoff point, you're going to say it's a high risk. If you use only epidemiological risk factors, you would to say there's no one is at this risk level. Whereas if you combine all the other risk factors together, you could identify 3% of the women at this risk level. Similarly, you could identify the lower risk group. Now, we need to, therefore, if you add more risk factors, you improve your risk discrimination, you improve your risk stratification, and of course, it has a better face validity. However, we need to be also considering the complexity of collecting this information. For example, if you're going to ask the information about their body mass index or their alcohol intake and so forth, these are risk factors that change over time. Therefore, it means that you need to do the risk assessment more than once. You can't do it one-off as you're using the polygenic risk score, but you can do it at any age and one-off. If you're using mammographic density, you can't do it at age 20. So you need probably going to do it at age 40 or so. And also it means that you have done already your first mammogram. There are implications. So we need to be considering, okay, there are trade-offs between the accuracy, the more comprehensive model versus the usability of them. Right? And this is therefore this is need to be considered on a context level, and it's an each population level to decision of which approach works best. Now, so far I've talked about epidemiological risk factors and polygenic risk score, and you might ask, wait a minute, what about the pathogenic variants. For example, what about if you not include BRCA1, BRCA2, and other risk factors? So there is a study done by a colleague in Canada, Michael Wolfson. He's developed a micro-simulation model, genetic mixing model, taking into account the Canadian population, the cancer incidence, the relationship patterns, and the genetics. And they've taken 4 million men and women, and they followed them over 200 years. And what they do is, therefore, we see, therefore, you can say what age you want to do the risk assessment, and then you define what is a high risk, what is the relative risk that you would do high risk, and then say, you know, whatever, you know their family history, you have their pedigrees over 200 years, and you know whether they are pathogenic variants carriers, and you know their polygenic risk score. Now, the thin lines, this is the actual one. The bars, the wider bars, is the one that we can assess. So let's look into it. Supposedly, we're going to do risk assessment at age 40. And we're saying that for everyone has a family history, you take into account for whether they have a family history or not. And then you're not including any of the other genetic factors, and you're considering high risk if they are twice the population average risk. What we see here is that we will be identifying some of the high risk group by just taking family history. Now, if you include things in addition to family history, if they have a pathogenic variant, you will be identifying some of the very high risk also people. But if you add in polygenic risk score, what we see is now you have a thick bar in the lower risk group. So you would be also identifying low risk groups. Now, if something else, if you're only using family history and it happened that your relative risk is very high threshold for being in high risk, even family history will not be identifying any of the cases. So what does this tell us? It tells us, yes, there is a value in having some of the pathogenic variants but if you're going to use it at a population level, it makes more sense to have the polygenic risk score because it is a better able to identify people. Not only the high risk population can also identify the lower risk population, where you can reduce also their screening if they don't need as much screening. The next question I come into the risk threshold. Okay, whether we should be using age varying threshold or whether we should have the same threshold applied to all. Back to my figure of your population. I know their 10-year risk. This is based on women in Canada. Now, one approach is, therefore, I would say, here we've taken a relative risk. For example, the high risk is, if you're the red one, if you have a relative risk of 2.8-fold higher than the population average risk for that age group, for example, age 60. Okay. What happens is that you will be identifying around 2% of the population as high risk for each age group. But all of them will be 2.8 times higher than their average age for their age group. But the 10-year absolute risk will be different because the 10-year absolute risk varies by age. For example, a woman at age 40, she would be 10-year absolute risk of 3.7%, considered as high risk. Whereas a woman age 60, she would have a 10-year risk of 8.9% to be considered as high risk. The alternative, if you come and say, I want to consider anyone who is a 10-year risk of 3.7% and above as high risk, what we're saying is that we're going to identify many more women as high risk in the older age group just because of their age. And look at it, therefore, you're going to have even about more than a third of the population will be considered as high risk in the age 60. And the relative risk, therefore here you're considering 2.8-fold as high risk in a woman age 40, whereas in a woman age 60, you're considering being in high risk if they have a relative risk of 1.1. Okay. So you're considering, by taking this, not taking into account that risk varies by age and using a constant age risk threshold, you're subjecting many more women to increased surveillance if they are considered to be at higher risk. Now, we therefore looking into the screening strategies, therefore, okay. So there are different ways of risk-tailored screening. There is not single way. It's you can either say we will keep everyone the same, except we want to increase screening to those with high risk, or keep everything the same, or except that we want to reduce the screening for the low risk group, or you want to tailor the screening to everyone the same way. Now, and what are the acceptable trade-offs? Of course, with everything, there is a trade-off, and therefore, it should be decided in advance of starting the process. But what is it that you want out of it? Are you looking, therefore, to get the screening strategy that gives you the maximum benefit, minimal harm, or are you looking to improve your benefit-harm balance? Are you looking to reduce your cost or increase equity? So this should be decided in advance, because the different strategies that you look, they will have a different outcomes, and which one to decide, it depends on what are the trade-offs that you are accepting. Now, what type of evidence? Therefore, we know that therefore we go for a randomized controlled trial, but these are not themselves are sufficient, because they cover only, therefore you can only study a handful of strategies, whereas in other approaches like modeling, you can do many more strategies you could study, and also you could study the implications on people who were not included in the randomized trial. So basically what I'm saying is you need the different approaches of studies. You need modeling studies to inform randomized trials to inform modeling, to inform decision, but also we want also implementation studies while we are gathering the evidence. Otherwise, by the time we get the evidence and then come and say, oh, to start to think of how we're going to bring this into practice, it will be a lost opportunity. There are ongoing randomized trials for breast cancer, the Wisdom in the US and the MyPEP study in the UK. But so far, MyPEP is in the Europe, UK is part of it. So far, the evidence that comes from decision analytical models. Give you an example is a risk-based screening in the UK setting. Here in the UK, we have a breast cancer screening program for women from age 50 to 70 every 3 years. So what we've done is to say, okay, let's model 3 different ways. Say there is no screening, say we do the same as the current screening program does, or we've taken risk-stratified screening. One way of looking at it saying, okay, we're going to screen from age 50 and every 3 years, but only we're going to screen those who are above a certain risk threshold. To identify the risk threshold, we've modeled therefore 99 for every modeled outcome for every percentile of the risk, therefore basically 99 different scenarios. So in a nutshell, here is therefore the different scenarios. Therefore, with every threshold, you have a proportion of the population who would be eligible and be screened. And here we're looking into the incremental cost compared to no screening and incremental QALYs. QALYs are quality adjusted life years. These are a summary health measure. Now, if you go to the right, therefore you're lowering your threshold, which means many more women would meet the threshold, would be invited to screening. The cost of the screening program will be higher, as you would expect. The QALYs, the benefits, also increase as we screen, but there is a point where we reach a plateau. Therefore, around if you screen 70% of the population. Afterwards, the program cost increases, but you don't get much benefit. There is diminished return with more screening. So this is from the cost effectiveness perspective. What about the benefit-harm balance? So here again, if we screen everyone, this is the maximum, the number of overdiagnoses you would expect. Whereas if we lower the number of, therefore if we increase our threshold, which is we lower the number of women invited to screening, we do have a reduction in overdiagnosis. But at the same time, we will have also less breast cancer death avoided. But overall, the amount of overdiagnosis, the reduction is much more than the amount of the cancer death avoided. So overall, you get an improvement in the benefit balance. Similar studies in the US, again, from the CISNED modeling group, they looked into risk groups defined by polygenic risk score, plus they added to it family history. They looked into changing the age of the screening interval, and they compared the results to the existing guidelines like the US Preventative Service Task Force, American Cancer Society, and so forth. And their findings is the same. If you do, you get better outcomes if you use a risk based on polygenic risk score plus family history more than if you use just polygenic risk score or just you use family history. And if you intend to keep the same number of screens as currently, but you redistribute so that the more screening for higher risk, less screening for the lower risk, you would come up with reduction in overdiagnosis and improvement in population level benefits compared to the US Preventative Service Task Force guidelines. Similar findings we have with prostate cancer screening. So far, the model-based estimates are promising, and that's why the trials have come up to find the evidence there. Now, operational steps, how we're going to bring it. Of course, running a program of screening program will be much more more steps needed and more complex. So first of all, you want to invite to come for risk assessment. Of course, you should know when and how often you're going to screen. You should have the evidence, and there should be policies in place to protect from third parties, to protect the privacy and confidentiality. And then once you've done your risk assessment, of course, you know which risk factors and you have a way of risk collection assuming. So you've done the risk assessment, you need to link the risk to the health records, and it's linked to be linked to the care pathway with screening way to be gone. And of course, everything you do here, it has to be aligned with the values, preferences, and respecting autonomy of the people. And of course, we should know the evidence of which intervention works for each group. And then if to run such a program, we need, of course, the funding, we need the infrastructure, IT system, and to manage this. And then you have to give the results. Therefore, there is a communication aspects. Therefore, in communication, why you're doing risk-based screening and communication, what does the risk and what does the new recommended screening is. And of course, this has to be, therefore, we need to be clear who's going to do the communication and how we're going to give the results out. It has to be aligned with the literacy level of the population we're dealing with. And once you've done everything, you're offering the normal steps that you do in any screening program. You offer your screening, you have your quality assurance and monitoring in place. So many more steps coming in. Give you an example, the last bit is an ongoing study, the Perspective INI study in Canada. It's a multidisciplinary groups are involved. So it has two main objectives. One is develop a new risk prediction models, therefore, so that we can have more cost-effective way of running the screening program, and also understand the optimal way of introducing a risk-based approach to the Canadian setting. The study is in Ontario and Quebec provinces. Now, if I look to the implementation aspects, therefore, one is there is a risk stratification tool, which is based on the CanRisk tool or based on the Bodicea algorithm, but it is being adapted to the Canadian population. And then there is an economic microsimulation study as part of it in order to identify which are the strategies that give us maximum or improve the benefit-harm balance and the cost effectiveness. But there is also there's also an invitation of 4,000 women were invited. This happened during the COVID time, the invitation, and where women were invited, and they provided the samples, and then they provided the information back to women, And this is to learn whether this is acceptable and feasible. Rather than asking hypothetical questions, we're looking into a real world setting. One has it, if they have their own risk level, see what is its effect on them and whether they are happy, and implications, which is a different, more personal than just being a scenario-based analysis. Now we're looking into whether there is and how there will be follow the recommended screening, whether they take the genetics, what are the issues with understanding the risk communication. We're looking also collecting data on the costing so that we can do the economic microsyn evaluation. And we're looking into the healthcare organizational level, what needs to be in place. The process, therefore, involves a woman invited from age 40 to 69 in Ontario and Quebec. Basically, what we have done, and therefore the two provinces have a different way. One is sending the letters directly, with other one is using more Facebook and media, because the way they run the programs are different, and in itself it gives us as a natural experiment to compare different ways of invitation. Therefore, the woman had to complete a questionnaire at baseline about risk factors. Then, when they were given the risk assessment, given the results, there's a questionnaire. A year later, another questionnaire, whether they followed the recommended and what are the long-term implications. When they will receive the collection of the information, they will receive a toolkit to provide saliva. And there was a new test was developed at the clinical grade level, done in a clinical lab, the estimation of the polygenic risk score. And also they have taken the mammographic density from existing mammograms and combine all this into the CAN risk tool to identify the risk of individual and then stratify them into different risk groups. We've developed an age-dependent risk threshold. We've taken what is currently in practice in Ontario. They have a high-risk program where they consider a woman is high risk if she has a remaining lifetime risk of 25% or more. We converted this into a 10-year risk, absolute risk level. Here it is, for example, for every age group, we have what is it, an average risk, what is a higher average risk, and what is a high risk in 10-year risk absolute level. For example, if a woman has been 50-year-old, she come up with has a 10-year risk of 4% based on this comprehensive model. Therefore, basically, this woman would be considered higher than average risk and would be given the recommended screening for this age group, for this risk group. Just quickly to show that, therefore, why the benefit of having the risk-stratified approach. So if you use an age stratification, our population of 4,000 women who've come, it's around, you have an 86% to be in the age group 50 to 69, which means this will be invited to screening, and 15% or 16% would not be invited. They are younger than age 50. Now, if you do a risk assessment, what actually we find that 80% would be around average risk, and they will receive the same way of screening every 2 years in Canada. Okay, and there will be some women, 16% is higher than average risk and 4% is high risk. Now, some of this, therefore, for example, a younger age group, 40 to 49, they wouldn't be receiving any screening, and now they've been identified as being in higher than average risk and high risk. They would be receiving screening, and also they will be screened for either every year or every year in addition to having a mammogram and MRI. So previously they were under screened. By having this, some women, you get the benefit of being identified earlier. Now you're going to say, okay, what about we do family history? Isn't it enough? Just a quick presentation. The dark one means they have a family history. Blue one means there's no family history. So it's around 12% have a family history. So if you look into if you do by risk stratification, so what we see is that those who have a family history, 60% of them are considered as average risk, so they don't need to be receiving more intensive screening. Otherwise, if you don't look into the risk level, they would be recommended to have more intensive screening. And And then also we see that some women who would be considered as an average, no family history and not receiving any further additional screening, some of them are high risk or higher than average risk, and they would be needing to be receiving additional screening. So some were over-screened and some are under-screened. Similar, if you use only mammographic density, so what we see is that some of those who have a high density still would be an average risk, and they don't need to go into an intensive screening. Therefore, they were over-screened, and others who were considered as not having a mammographic density and were not referred for intensive screening, actually they are at high risk and they would benefit from it or further screening. Further analysis is being looked into what risk factors we can modify, and at the moment we're just doing in the process of analysis of all this data. So in summary, I would say what we know so far is that risk-stratified screening could improve the benefit-harm, cost-effectiveness of the screening program. But of course, the implementation is very much context-specific, and it's not a single approach. You need to have look at it from a whole systems approach. And it could be many twists on the way. It's a bumpy ride. But the thing to think about is that there's a fine balance. You don't want to be rushing. We want to avoid premature translation, we say. But at the same time, we don't want, by waiting a lot until we get the evidence, we don't want the innovations to be lost in translation. Thank you very much for your attention. I'll be happy to take questions.
Thank you so much, Nora. That was an excellent talk. I don't know whether anybody has any questions or comments. Maybe I can start with one. So in the UK, as in other healthcare systems, there is organized population screening in the UK going since 1988. So women over the age of 50 are expecting to be invited to the program and to have regular mammograms. And in a way, with risk-stratified screening, they will be told, those that are at lower risk, not to have, and they do not need to have the screening. And in a way, when something is established and taking it away, the population always feels that that is actually quite a complex and challenging, I guess, lack of intervention rather than implementing more frequent screening. So I guess the high risk, that is probably easier to explain if you have to have a particular different risk and a more frequent screening. But when you are taking something away that's already been established for many decades, what happens then, and how do you think that the women would feel?
The implementation is more difficult than the implementation. So it's in surveys, whether it's in Canada, in the UK, and also across 7 different countries in Europe, they are consistently the same finding. If you say we want to screen more, there is more appetite. And if you're going to say to screen less, there's less happiness, therefore less people are happy with it. Similarly, survey of the healthcare professionals in Canada and here in the UK, so similar findings. They're happy to have more screening, less happy if there will be less screening. So this requires, if there is a true reason for just justifying it, if there is a true benefits and there are true harms that you're trying to avoid, it needs an additional work of therefore getting the message out clearly why you're doing this. Is it, if you're doing it as a way of rationing, some people will think, therefore, yeah, it's acceptable. But if you're really preventing, therefore, some people going unnecessary, therefore, unnecessary invitation, therefore, it requires lots of work in communication and explaining the reasons. But also you need to explain that when you say someone is low risk, it doesn't mean there's zero risk. Some of them will have a breast cancer, as we do see in women who are younger than age 50 and older than age 70, who are not invited yet develop cancer. So the message should be very clear. What does low risk mean and why this is being the way we're heading with?
Thanks, Neil. Opening the floor to questions. I don't know whether anybody else has any other questions or comments. Oh, yes, Michael. Please go ahead.
Yes, thank you. I hope you can hear me. Very interesting talk. I wonder if you could comment a little about earlier detection and implications for survival and treatment.
Implications on earlier detection and survival.
Survival and treatment.
Yes, the whole purpose of this is what evidence from randomized controlled trial will come on the mortality reduction. Whether there is what the current trials are looking, whether there is no disadvantage in survival or mortality reduction by having this approach. Model-based estimates show yes, but the models should be informed by a trial because we don't have by risk level. So the whole purpose, if you can show that there is no reduction, therefore there is no reduction in the mortality reduction, so no, and then that's where we need the evidence on effectiveness and the benefits.
Great, thanks. I hope that answered your question. I guess I would have a question about the Wisdom and the MyPEBS trials. Are they close to reporting? When will that data be available, or is it something we'll be looking for another 5-10 years before we know what the impact is, or even longer?
Therefore they are looking for a proxy outcome at the beginning, so probably in the next year or so. It was all happened when MyPEBS started. It was the COVID time. It was a difficulty of recruitment, all the challenges. But they are expecting to have the preliminary findings next year or so. But it's approximation. It's looking into stage rather than outcome. Mortality, as you know, you need to be waiting for 10-15 years to see effect on mortality.
Okay, and as we know, and we've been discussing this, I guess, in our conversations at UCL, that stage shift is not a good surrogate marker for mortality in population screening. I guess their results could infer what may be possible, or if there's a stage shift and the magnitude of the stage shift with risk-stratified screening, and I guess compare that with all the breast cancer screening trials and all the modeling that's been done, and a lot of controversy and discussion in the literature about what is that effect. But I guess that would be the first comparison that could be done. Am I correct?
That's the first result. It's not the final. It's not the end of the study, but that's the first outcome that they can first analysis results. The interim findings is about looking into the stage, but of course the study will be continued in 15 years for the results to come up, and that's the challenge. You need to have a randomized trial evidence. Now it's different in breast cancer where you know the evidence that what is stage is associated with outcome. It's different when you have a completely new condition where we don't know whether screening works or not. Now, therefore, if you're going to wait the trial, you need 15 years. So by the time 15 years, I don't know what technology advances, and the things are moving faster than we get the results. So that's the catch-22 field is. If you're waiting for the full evidence from trial results with the mortality outcome, then it will take many, many years until we have things brought into clinical practice when the evidence comes. Or are we going to say, yes, we know that evidence that screening works. We know what is the survival or the mortality reduction by stage. Can we estimate what is expected? Start with it because we do have screening programs. And can we use a randomized health system trial where some areas are being tried as you go and then change as we go? But we learned during the COVID that people were open, you change the guidelines because more evidence comes. Would this also apply in other settings? Or do we want to be fixed and this is therefore we know what it is the right you need to do it? Or do we need a mindset shift? Therefore people are saying yes, things can change when new evidence comes in.
Good to see. Ronglin, you have a question? Please go ahead.
Yeah, thank you. Thank you, Laura. It's a very nice presentation. I learned a lot. I have one question about your stratified screen. Have you compared all the compare across all the strata, and which strata were more cost effective and more beneficial?
Yeah, when it's not about therefore we're looking into which strategy is more cost effective and gives the benefit. The way we've looked into in one study, therefore I presented is one strategy, which is screen everyone, only those above a certain risk level. But the American one, they looked into change the age. And there's a recent publication also from the UK setting where there is a change the age and change the frequency. And we've looked into what age is the optimal and what frequency is the optimal. So that's not the risk strata, rather than the strategy and how you're going to do. Yes, there are studies where, and that's why the trial is difficult, because the trial can study only two. Here you're going to change the start age, stop age, frequency, and we have one study which is we are in the process of writing. We've studied 500,000 different strategies for different combinations that you can look, and from there identify the few that can meet whatever criteria we said. We want to reduce interval cancers. We want to reduce overdiagnosis, have a same or more benefit in reduction in death from breast cancer. So that's the ongoing work. But that's what we need with the simulation studies that can answer. So.
Yeah, exactly. Yeah. Thank you.
Don't know whether anybody else had any other questions or comments. If not, would like to thank you, Nora, for an excellent presentation and also for scheduling this on the 21st of December, just before the Christmas break, when you must be very busy, just like with everybody else who has joined us today. So thank you so much to everyone for attending just before the Christmas break, and wishing everybody happy holidays.
Thank you very much.
Thank you.
Thank you, Nora.
Thank you.
Bye.